Start then. Today we'll be discussing the second part of acute encephalitis syndrome. So we have started with the CNS infections in the last lecture. We'll have a quick review of what we have looked at uh, in the previous section. So we have looked at the definition of AES, the etiology and clinical features partly. So I won't go into the details again. So this was the definition given by WHO, and these are the various definitions of encephalitis, meningitis, and meningoencephalitis. And another definition put forth by International Encephalitis Consortium. So based on whether these they are minor criteria and major criteria. So based on that, you'll define its definitive or confirmed areas. So we've looked at the various etiologies. What you need to remember is basically encephalitis per se, as a common misconception. It's not just an infection. It is inflammation of the central nervous system. So that could be infectious as well as non-infectious. So we tend to focus more on the infectious encephalitis because they are commoner in India, but also look at definitely watch out for non-infective encephalitis. So, but the umbrella term for that is encephalitis syndrome. So non-infective are also equally common, especially the main concern here is the key takeaway for this lecture is non-infective encephalitis needs to be identified with very high suspicion because the treatment is completely going to be different. But we know that we have been treating encephalitis syndrome since a long since many years now. We know the bacteria, we know the common viruses based on the epidemics. We have also looked at the epidemics last time, but identifying a non-infective or an inflammatory encephalitis or ADEM, NMOSD, ANEC, all this is extremely important because the treatment is going to be non-traditional. We are not going to be relying on antibiotics and antivirals because the treatment is going to be immunomodulation and steroids in these conditions. So it's very important to identify this, and most of these entities actually respond very well to steroids and other immunomodulations. And also it gives us clue whether we need to step up or go more aggressive on immunomodulation. For example, we have different protocols for ANIC now. ANIC is acute necrotizing encephalopathy of childhood. So in this, we start with steroids, and we eventually, upfront we go for Plex or IVIG, and there's a role of upfront tocilizumab in this condition. So diagnosing this condition and suspecting this clinically also is very important. So not just focus on the infections, but also the non-infectious conditions is very important. So we have looked at the organisms, various viruses, bacteria across the globe. We've looked at the common viruses in India. As a quick review, the commonest viruses in India would be Japanese encephalitis. First is dengue, then Japanese encephalitis, then you have scrub typhus in various parts of India. And then other arboviral infections in India are also very common, like dengue, chikungunya, leptospira. Leptospira, again, is common in the Sri Lankan border, and also in the Tamil Nadu, leptospira is pretty common. And leptospira, as you know, it causes Weil's disease. So it spreads from rodent urine. So water contamination, leptospira is also, a lot of cases of leptospira have been reported from Mumbai as well. So this is a map of Japanese encephalitis. UP remains the first state with highest prevalence of Japanese encephalitis. We have also looked at the incidence of various viruses across the globe, and also looked at the various points in the history, what we have to look for. And we've also looked at clinical manifestations. All that I need to say here again to quick review is basically we cannot definitely exclude meningitis if the meningeal signs are absent. Especially remember in a child less than 2 years, the meningeal signs would usually be absent. And the absence of meningeal signs does not necessarily rule out a CNS infection. And it's always a combination or the constellation of meningeal signs is extremely important. So if the child does not have neck stiffness, he may have, Koenig's or Brzezinski. He may not have all three, but he may have one or two. That is itself is another important clue for working up accordingly and treating accordingly. And I've also discussed there's a new, it has been used commonly in adults, but I think Joel's accentuation test is also one of the tests which is not specific, but is very sensitive in meningitis. So we have demonstrated all the meningeal signs, the tripod sign, Joel's accentuation being the sensitivity being very high. and the combination of various medical science being more important than one particular science itself. We have looked at various studies as well. So quickly, we have also discussed about meningism, that is the signs of meningeal science are present, but meningeal irritation are present, but from there's no active meningitis, but there's something, irritating the meninges. So you have these conditions which show up when you have, meningeal signs, but no CNS infection. So we have also looked at how to approach a case of meningitis empirically, what test needs to be done, when do you do an LP, when do you do neuroimaging. So all that we have discussed. And we have also quickly looked at various newer investigations that we are, doing it commonly, and they're easily available now. So back then we had very few tests to actually identify the organism. So back then we had cultures and latex agglutination for pneumococcus. And slowly we are moving for a more sensitive. You see, the culture sensitivity of CSF is not pretty high in CNS infection. So many times we end up with a condition wherein we don't have uh, an organism known. So it ends up being, a non-specific bacterial or viral infection, or a bacterial meningitis or viral meningoencephalitis. We don't, get to know the exact virus, what it's caused. So now with the adequate availability and free access to these various tests, so now we know that we have multiplex PCR, that is the biofire. So multiplex PCR, as the name itself says, it simultaneously looks at various organisms by the technique of PCR. So it's almost like an antigen detection. So depending on the panel, you need to look at the common viruses, bacteria, fungi, accordingly with the suspicion. The commonest ones are actually covered in the CNS panel of the biofire or the multiplex PCR. So what is more, it's very important that, to know that PCRs do not take a lot of time, and they are not, they're pretty much expensive, but I think the costs are coming down day by day. So here you see the TAT is less than half a day. Usually you get the reports within half a day. So we have also looked at various signs and how to identify what are the contraindications for a lumbar puncture. So we are going to be getting into the case scenarios. So these are the real life scenarios wherein, the clinical setup looks like an AES picture, but we need to use various tools. Especially neuroimaging is a very crucial role, because most of these non-infective demyelinations or non-infective inflammatory conditions of the brain are inflammatory, and they are clinico-radiological diagnosis. See, you cannot diagnose ADEM or ANIC without an MRI, because the diagnostic feature is there in the neuroimaging. So do consider an MRI early on in these conditions, and by default, any CNS infection needs an MRI. So there was a school of thought that, I mean, few years and a decade back, that the gold standard still is lumbar puncture. I agree with it. Gold standard is lumbar puncture, because you'll identify the organism, you'll understand the cytology, you'll understand the protein sugars, the biochemistry of what exactly is happening in the CSF. But especially for identifying the patterns, the neuroimaging patterns, or the pattern recognition and the diagnosis of these non-infective inflammatory conditions of CNS which cause inflammation, are particularly diagnosed on MRI. So MRI is mandatory in any CNS infection or any AES. So we'll quickly look at various case scenarios. So this is a case of an 8-year-old boy who came with acute onset fever and altered sensorium. And this child also had few episodes of seizures, of focal seizures. So quickly, this was assessed by the pediatrician, and they have got an MRI done. Uh, you see this. What do you see in this child? Quickly wait for 10 seconds. So try to identify the sequence of the MRI first, and then see the abnormal findings. So if you're thinking if you see, this is the ventricle, this is the frontal horn of the lateral ventricle, this is the occipital horn of the lateral ventricle. The CSF is dark. Okay, the CSF is dark, it must be T1 or flare. And so you see white matter is darker. So this is flare image of an axial sequence. Okay. And what do you see here? There is if you identify these structures, these are thalami. So there is symmetric bilateral thalamic swelling. If you see this flare hyperintensity in the center, followed by a thin rim of heterogeneous hyperintensity, patchy hyperintensities. So bilateral thalami are involved. Apart from that, there's subtle periventricular white matter involvement. And if you see on the second, the right-sided picture, there's involvement of the brain stem as well as the cerebellar hemisphere. The dentate nucleus is also involved. So this is a condition where we have thalamus involvement, brainstem involvement, cerebellar involvement. So this is a typical picture of this is called the trilaminar sign. So this is a classical picture of ANIC. So here, neuroimaging becomes extremely important because this pattern can only be seen in MRI, very subtly in CT as well, but CT is not a good diagnostic tool in CNS infections. So here, this patient needs a very rapid escalation of immunomodulation steroids, IVIG, Plex, or even tocilizumab needs to be considered based on CSF IL-6. So in these cases, what we do is basically we do a CSF analysis if the raised ICD signs are ruled out. And then we do the routine cytology and we send various parameters that we already know, that sugar, protein, cytology, and cells. Apart from that, we also send something called CSF interleukin-6 levels. So if you see the pathogenesis of ANIC, that is acute necrotizing encephalitis, is basically a cytokine storm which happens in the brain. So we need to look at various cytokines, but there's no point looking at all the cytokines in the CSF. But the prototype interleukin, that is interleukin-6, is checked in the CSF. And if this interleukin-6 is more than 5 picogram, so that is significantly high. So if the IL-6 is high, you can have an early on consideration of tocilizumab. So that again is a very important key marker in the treatment. So this is another child with around 8-year-old child coming with acute onset seizures and acute onset encephalopathy. On the MRI, if you see this is a T2 sequence because the water is white, that is the CSF is white. And what do you see there? There are bilateral white matter, fluffy shadows. You see this left right occipital region, left temporal region, the right temporal region, and bilateral centrum semiovular white matter is involved. And even here, the thalami are also involved. And there are periventricular hyperintensities as well. So this is a pattern which you see right and left are different. This asymmetric, multifocal, cotton wool-like or fluffy cotton wool-like shadows, hyperintensities are typically seen in ADEM, that is acute disseminated encephalomyelitis. Again, this condition is extremely important to identify, and the diagnosis is usually made by an MRI. So it's a clinical radiological diagnosis, and it dramatically responds to steroids. So you need to start steroids at a very high dose and maybe consider another level of immunomodulation if the child is not responding. And these are usually under the umbrella of another entity called MOGAD. MOGAD is basically MOG-associated demyelination. This is another child, another interesting one. So this child has actually come with a history. This is a 4-year-old child who came with the history of fever 2 weeks back, and now the child suddenly has multiple seizures, a sudden clustering of seizures, and a severe encephalopathy. And we have admitted this child and have considered CSF. Before that, we did an MRI. If you see, the MRI actually showed these kind of changes. So what do you see here? This is basically a sequence of diffusion restriction. So if you see, there's diffuse white matter diffusion restriction in the bilateral cortical, subcortical U fibers, frontal white matter, and there's even the temporal white matter, the occipital white matter, occipital radiations are also affected. If you see this involvement of the splenium of corpus callosum. So this is a condition which is called ALERD, ALERD, that is acute leukoencephalopathy with restricted diffusion. So this condition is again a post-infectious inflammatory condition. So this is also cytokine mediated, which causes a very significant involvement and inflammation of the white matter alone. So these children can present with seizures. These children can present with tone changes. These children they present with encephalopathy. They act very similarly like any other CNS infection, but it's very difficult to diagnose these without the MRI. So this is again a clinical radiological diagnosis. So again, ALERD is a post-infectious autoimmune immune-mediated phenomenon. So immunomodulation is extremely important. So upfront, high-dose pulse prednisolone needs to be considered, and if needed, there's role of DEX and IVIG as well. So, so this condition, if you see this, the similar condition can also be seen in an entity which is called a rotavirus encephalopathy. So if this picture would have been in a neonate who has presented on day 5 of life or day 10 of life. So let's take this, the neonate is just 5 days old. Perinatal and antenatal history was unremarkable. The child was breastfed from day 1. The feeding issues were not there. On day 5, the child suddenly has a seizure. And we did consider MRI to find out the focus. And MRI showed this type of picture. So if this picture was there in an adult patient or a very a pediatric child after a viral infection, this would be an alert. This very similar picture is also seen in this condition called rotavirus encephalopathy. So rotavirus and paracovirus. So these are the two viruses which cause a typical white matter involvement like alert. So if you see the nomenclature of this, it's not actually rotavirus encephalitis, it's rather rotavirus encephalopathy. So this is hypothesized that they have taken cases of rotavirus encephalopathy and they have done CSF studies, blood studies, and the stool studies. So most of them who actually had this kind of picture and seizures and encephalopathy on day 5, none of them had any isolation of rotavirus by PCR from CSF per se, but they did isolate rotavirus in the stool. So these are specific kind of strains of rotavirus. They are called the nursery strains. So they basically are shed in the stools, but they have systemic spread. The viremia happens, and the most of the CNS toxicity which happens because of this is basically because of the chemical or the chemical mediators of the rotavirus, not per se the viral invasion itself. So that's why the CSF is usually negative for PCRs. So that's why they actually call it rotavirus encephalopathy rather than rotavirus encephalitis. So again, it doesn't have any specific treatment. It needs conservative management, and usually it's self-limiting, and the mortality and morbidity is pretty low. When you repeat in MRA after like a couple of weeks, which is not usually indicated, you see this pattern will actually fade by itself. So this is another condition which is called MERS, that is mild encephalitis with reversible splenial lesion. So some also use the term called restless, the same thing. So here, if you see the nomenclature of this entity itself, there is encephalitis. The child has mild encephalitis with a neuroimaging finding, which is consistent with only diffusion restriction of the splenium of corpus callosum. So if you see here, this is the splenium of corpus callosum. So rest of the MR is essentially normal, but sometimes there are types of MERS wherein there's MERS type 1 and type 2. In type 2, you'll have involvement of white matter. The classical MERS, you only have involvement of the splenium of corpus callosum. So this is called the MERS or mild encephalitis with reversible splenial lesion. If you see, they've actually said it could be encephalitis or encephalopathy. So there are few viruses which are commonly known to cause this entity, but classically it is known to happen in influenza A, influenza B, mycoplasma, and rickettsia, and sometimes adeno and mumps virus. It's pretty non-specific. Any virus can cause this. So it can be a direct viral invasion, that is encephalitis, or it could be a viral mediated chemical or a cytokine mediated or autoimmune or immune mediated phenomenon. So it's mild encephalopathy or encephalitis with reversible spleen infection. So this is again not very uncommon. We see it now and then. Again, the role of immunomodulation is extremely important in these conditions. Okay, this, if you see the images again, as the answer is rightly put, so there is extensive involvement of the temporal lobe or the motor cortex. So this, the predilection for the temporal lobe in a case of acute encephalitis syndrome, we need to think of uh, commonly herpes encephalitis. So we see herpes simplex 1 and herpes simplex 2, these are the two viruses which particularly affect the temporal lobe. The logic behind this is, again, we'll discuss this in the coming slides. So whenever we have temporal lobe involvement with EEG, with showing, PLEDs, that is periodic lateralized discharges from that particular temporal lobe, and the child has focal seizures, sometimes focal status with encephalopathy, start thinking of herpes encephalitis, because it's extremely important, because this has specific management, because you need to give high dose acyclovir for at least 14 to 21 days. Uh, so identifying this again is very crucial. So here, this is a case of Japanese encephalitis. As I said, the pattern of ANIC, that is acute necrotizing encephalopathy of childhood, is quite similar to dengue encephalitis and Japanese encephalitis. If you see the paradox here is dengue and Japanese encephalitis can themselves cause a very similar pattern of ANIC, and these two viruses are also known to cause ANIC. So if you see here, Japanese encephalitis will have bilateral thalamus involvement and bilateral, midbrain involvement, especially in Japanese encephalitis. And even dengue also has thalamus involvement, brainstem involvement, and cerebellar involvement. They're quite similar. But the trilaminar sign is very pathognomonic of ANIC, unless you can't see that in Japanese encephalitis and dengue. Dengue, you have two layers, that is called the double donut sign. We'll discuss that in the later slide. So if you have trilaminar sign, that is almost pathognomonic of ANIC. But if you have bilateral thalamus involvement with midbrain, brainstem, and cerebellum involvement, that could be Japanese encephalitis, that could be dengue per se, and that could also be ANIC. Okay, or it could be Japanese encephalitis or ANIC or dengue-induced ANIC. It could be either way as well. So again, I won't go into the details of it because identifying the organism is extremely important because apart from the immune-mediated encephalitis, because these are the treatable infections. Like routinely we do give the cocktail of ceftriaxone, vancomycin, and acyclovir. But with herpes simplex virus, it's the duration of that is also pretty important because you need to give it for at least 14 to 21 days in a documented case of herpes encephalitis. And before you stop the acyclovir, you need to document the CSF again to document there is negative HSV PCR. And varicella zoster is also very common, very underrated. You know that varicella or chicken pox has a lot of complications, and there are varied complications in CNS as well. There you have varicella zoster encephalitis, and you also have something called varicella, post-varicella vasculopathy or post-varicella vasculitis. This is also a very common entity. Again, it needs acyclovir for pretty much the same duration, 14 days at least. With with other organisms, we have the empiric antibiotics being covered. One specific or exotic infection is brucella. Neurobrucellosis is also not uncommon in India, where there is exposure of contaminated milk and uncooked meat, exposure to raw milk from cows, and handling of cow milk can also call brucellosis. So when you have brucellosis, you have typically presence with pyrexia of unknown origin. You can have non-specific hepatomegaly, and sometimes you can also have CNS infection that is in the form of encephalitis. So the traditional antibiotics would not work in brucella. Despite ceftriaxone, these children will have persisting fevers. You need to give a combination of doxycycline and rifampin along with ceftriaxone. So identifying this again will be very important. Will have treatment implications. Rickettsial fevers. Rickettsial fevers are extremely important in India because they are pretty much underdiagnosed and underrated. Particularly if you see Rickettsia sushugamushi, that is which one causes scrub typhus, is pretty common in India, especially in northern India. So they can have a varied presentation. So if you see whenever you have a child coming from a hilly area or a hostel with a lot of forest area and flora, so you have exposure to ticks and mites. So most of the rickettsial infections actually happen with the exposure of ticks and mites, depending on the organism. But the common ones here in India are scrub typhus, that is Rickettsia sushugamushi. And very rarely you have Rickettsia prowazekii here, that is Rocky Mountain spotted fever, and other infections also not that common here. If you see, Rocky Mountain spotted fever is common in the United States. And the other rickettsial atypical infections like Q fever, French fever are not that common. But in India, I think you need to think of scrub typhus whenever you have a child with a rash, a very erythematous maculopapular rash coming to you with fever and non-specific hepatomegaly, sometimes thrombocytopenia. So you need to think of rickettsia because the treatment is going to be again different. You need to consider azithromycin or doxycycline. Cryptococcus, again, a special note on Cryptococcus because the treatment implications are very, very quite different from what we do. So in Cryptococcus, start thinking about Cryptococcus whenever you have a subacute to chronic onset CNS infection in the background of an immunodeficiency. So the immunodeficiency is usually in the form of retroviral disease, a long-standing chemotherapy, or a combined immunodeficiency. These are the three situations, and rarely long-term steroids can also cause immunodeficiency, which can predispose the patient to have cryptococcal meningitis. Again, traditionally, we have CSF studies like we had India Inc. training before, a decade ago. But now we have cryptococcal antigen testing, which are more sensitive and more easy to perform and easily available. And the PCR, the multiplex PCR also picks up the cryptococcus in the panel. So in cryptococcus, usually the induction therapy would be amphotericin B plus flucytosine. That would be for a couple of weeks to 4 weeks. And after that, the maintenance therapy is going to be for at least 1 year. So the maintenance therapy usually involves your fluconazole, amphotericin B, plus or minus flucytosine. So this is the protocol, which is quite different because, again, diagnosis is extremely important to start these. And unless it's treated, this has very high morbidity and mortality. So these are the, I think we have discussed this in the previous session that, based on the CSF studies, that is based on the pattern of cells, the color of the CSF, the differential counts of the CSF, we have particularly diagnostic clues. Very often it happens that the patient won't be affordable to get a CSF PCR done, or maybe the cultures are not showing up any organism. So in this condition, actually, we need to have a provisional diagnosis of what we are dealing with. Is it bacterial? Is it viral, tubercular? Because empirically, sometimes we need to start medication for tuberculosis as well. So quickly, overall, if you see, the opening pressure would be high in tuberculosis because in tuberculosis, you're going to have signs of raised ICP. So tuberculosis TBM usually has a subacute to chronic concept type of picture, wherein the child has an ongoing fever, which is going for 2 to 3 weeks, and then you have, cranial palsies and encephalopathy. And by the time they come to the hospital, we do an LP and an MRI. Usually they'll have subtle or at least, overt hydrocephalus. So the opening pressure is usually going to be high in tuberculosis. So that is one clue, but it is not specific for tuberculosis. It can be high in bacterial meningoencephalitis as well. And regarding opening pressure, it's not very again specific. So opening pressure is extremely high. Think of fungal tuberculosis, again, because of the hydrocephalus. Coming to the color of the CSF, CSF is usually clear, which doesn't have any color to it. But if you have yellowish to cloudy type of appearance, it can be seen in pyogenic or bacterial meningitis. And if you have, again, cloudy and sometimes blood tinged CSF can also be seen, that the commonest cause would be traumatic TAB. But blood tinged or a pinkish type of hue to the CSF can be seen in herpes encephalitis. And the cobweb, the traditional cobweb, which is mentioned in the tubercular meningitis, is not very commonly seen. But again, you have the cloudy type of CSF in tubercular meningitis. Coming to the counts, if you see, the normal counts are less than 5. Even if you say a normal child can have 2 or 3 cells, it could be pretty non-specific, it could be epithelial cells or even PLC. But anything more than 5 needs to be considered significant in a case of AES when you do a CSF study. But typically in bacterial meningitis, which is untreated, you have very high cell counts, at least more than 100. If it's in the initial stage of the infection, it will be at least 100, or if it's partially treated, it's 100 to 200. But if it's a full word, a full-blown meningitis, a pyogenic meningitis, usually the cell count will be 200, 300. It can up to range to 1,000, and even in the severe case of ventriculitis, it can go up to 10,000s also. So that's typically very high counts in bacterial. When you compare to viral, the cell count won't be very high. It can range between somewhere between 100 to 200 and sometimes till 500, not more than 1,000 maximum. So again, here, how do you differentiate? Bacterial usually have neutrophils as the predominant cell type. So you need to look at the differentials. If it's like 65, 75, 90%. So usually it will be more than 70% of neutrophils in bacterial in an acute setup. Viral, usually you have lymphocytes, as you all know. In tuberculosis, again, you'll have lymphocytes, but here the cell count will be, in the range of 500 to thousands in tubercular meningitis. But here the key takeaway is basically there is significant hypoglycemia, that is decreased sugar in the CSF when compared to the viral. And the decreased sugars can also be hypoglycemia can also be seen in the bacterial meningitis. So these are from differentiating features, and the protein is going to be extremely high in tubercular, also pretty high in bacterial. But the viral, you have very borderline or normal levels of protein. So these are few clues wherein you can differentiate. But in non-infectious immune demyelinations, you have non-specific elevation of lymphocytes. The lymphocytes in ADEM, ANIC, they usually range from less than 50 to 100. Usually does not cross 100. Usually like 10, 20 cells, lymphocytes would be there, and the protein would be very slightly elevated. The glucose would be normal completely. So this is a picture of a non-infective, autoimmune or immune-mediated encephalitis, what you typically see in ADEM or ANIC. Okay. So these are the other viral infections which have discussed. I mean, I won't go to the details. These are the patterns of various, the neuroimaging patterns of various infections. We have already discussed this. Herpes we have discussed. Rasmussen's is one of the entity which is primarily immune mediated, wherein you have one side of the hemisphere being involved. We'll also look into that in the coming slides. And I've also mentioned that paricovirus and rotavirus infections are very not uncommon, but they're usually seen in the neonatal age group. They have diffuse white matter involvement. So this pattern can be seen in rotavirus and paricovirus commonly, but can also be seen in a condition called chikungunya encephalitis. With the mother has chikungunya and the neonate has the chikungunya as well. So this pattern can also be seen in chikungunya encephalitis. So I was discussing about herpes encephalitis. The logic behind this is because usually herpes simplex 1 and herpes simplex 2, both of them can are spread by a sexually transmitted disease, and it can sometimes spread from the mother to child as well. So usually you have herpes labialis. So herpes labialis is basically in the form of a cold sore or a small eruption, what you see in the lip or the buccal mucosa. So the access from the buccal mucosa, it goes via the trigeminal nerve up to the cribriform plate, and the cribriform plate is very close to the medial temporal lobe. So that's why it has a direct invasion going through the nose, the nasal cavity, the cribriform plate, and directly to the temporal lobe. So that's why it has a specific predilection for the temporal lobe. So that's why it's called the temporal encephalitis. A very similar picture of temporal lobe and the limbic encephalitis is seen in autoimmune encephalitis as well. That is also needs to be a common DD in a case with temporal encephalitis. So hippocampus, this is, we see the trigeminal ganglion is very close to the hippocampus. So hippocampus is a part of your temporal lobe. So the same pattern can also be seen if you have the child has an eye infection. So that is called the herpes simplex ophthalmitis. So again, the spread by ophthalmic nerve to the brain. So the commonest is through the trigeminal nerve. Okay, this is a child, again, we have discussed this is a child with paricovirus infection and neonate with encephalopathy, and the MRI showed diffuse involvement of the white matter with diffusion restriction. We see the radial spoke-like pattern. This is called the radial spoke-like pattern. The frontal white matter, the corpus callosum, genu, and the splenium both are involved. You see the cortical ribboning, or basically the occipital radiations are involved. So diffuse white matter involvement in the form of cortical ray or the radial spoke-like pattern is seen in paricovirus and rotavirus. So this is more common in paric. So this we have discussed. Herpes simplex can have a disseminated. I won't go into the details of the description of systemic HSV infection. So this is again a child with paricovirus infection. We have discussed this. This pattern is pretty similar to rotavirus infection. Can also be seen in chikungunya encephalitis. So paricovirus sometimes also it is a very a tricky situation. Sometimes the neonates are pretty much asymptomatic. They can have only fevers, but sometimes it tends to have a systemic involvement and have this type of rash, what you see here, typically involving the palms and soles. So that's why they call this the booties and the TT syndrome. Basically, it has glove and stock like wherein you have foot and the soles being involved, and also the palms and soles can be involved. Yeah. So this is the clinical characteristics of paricovirus infection. It can present with fever, irritability, poor feeding, diarrhea, rhinitis, rash. So it's pretty non-specific, but not very uncommon. So this is another child with herpes simplex encephalitis, as we discussed before. This is the left temporal lobe, which is completely showing hyperintensity. So this is temporal encephalitis, a typical herpes simplex encephalitis. It was confirmed on the PCR. This child was started on acyclovir and was given for 14 to 21 days. So this is herpes simplex 2, again, bilateral. So you can have bilateral or unilateral involvement of temporal lobes. Again, if you see, the left temporal is completely gone and the right temporal is also involved. This is the insular cortex, which is also part of temporal lobe, which is involved in these patients. They have refractory seizures. They can have, status. They can have focal status because the insula is involved. So this is a child who has come up with features of AES, that is a history of rash and fever 2 weeks back, and now he has presented with acute encephalopathy. So here, if you see this involvement of bilateral, not bilateral, but asymmetric involvement of the thalami, and the left thalami is hyperintensities. But the MR angio looks normal, and the non-specific hyperintensity is in the basal ganglia, that is the lentiform nucleus as well. So this pattern of, the thalamus and the basal ganglion involvement can be seen in a lot of viruses like varicella, Epstein-Barr, etc. So this child had a CSF PCR positive for Epstein-Barr infection. So this is a pattern which can be seen in Epstein-Barr and other viruses. So this was another interesting child. This child has come with acute onset encephalopathy and acute onset unilateral dystonia and focal seizure. So when the MRA was done, there is unilateral or left-sided restricted diffusion in the caudate nucleus, putamen, and also thalamus. If you see the pattern of this, then when you have involvement of caudate, putamen, and thalamus, so this is technically a common area which is supplied by the lenticulostriate vessel. So obviously, when you have this pattern, start thinking that there could be involvement of lenticulostriate vessel. So when we did an MR angio, we could notice a very focal stenosis in the M1 segment of the MCA, the middle cerebral artery. So the lenticulostriate actually branches from here. So there must be insufficiency of the lenticulostriate vessel. So this pattern can be seen. It's called focal cerebral arteriopathy. It can be seen after viral infections, especially after varicella zoster. So this child had history of varicella infection 2 weeks prior. So post-varicella vasculitis or post-varicella vasculopathy is also a very known entity and a common entity in India. So these are the various patterns we see. I've already discussed herpes simplex, the temporal lobe, varicella zoster, Epstein-Barr, basal ganglia, rotavirus and paravirus, the deep white matter, radial spoke-like pattern. Enterovirus, we have not discussed this. I think enterovirus, I think we have more slides coming up. Enterovirus typically affects the brainstem and the spinal cord. Cerebellitis, there are two things in cerebellitis. You have to think of post-viral cerebellitis. That could be an immune-mediated phenomenon. Sometimes the virus itself has the invasion to the cerebellum, so that can be seen in varicella zoster and Epstein-Barr. Myelitis, as I said, enterovirus. So myelitis is basically spinal cord involvement. So when you have brainstem and spinal cord being involved, think of adenoviruses and enteroviruses. Okay. So I won't go into the details of the primary CNS vascular. So this, if you know that there is something called systemic vasculitis, I think you have read that when you're in general pediatrics, because we have something called large vessel vasculitis where you have Takayasu and James arteritis. In children, we see Takayasu arteritis in adolescents. This medium vessel vasculitis, that is polyarteritis nodosa and Kawasaki. But small vessel vasculitis, basically henoch-Schönlein purpura, microscopic polyangiitis. So these are basically the vessels which can involve your CNS vessels. So here we have few conditions wherein polyarteritis nodosa and microscopic polyangiitis, sometimes they can have CNS involvement. And very rarely, Kawasaki and polyarteritis nodosa can also have CNS involvement. That is the primary vessels, that is MCA, ACA, they do come under medium size, but the distal branches come under the small sized vessels. So sometimes, rarely, Kawasaki can have CNS involvement. Polyarteritis nodosa can cause vasculitis, especially middle cerebral artery. Bilateral middle cerebral artery focal stenosis is a known entity in polyarteritis nodosa. So do think of when you have ruled out post-infectious vasculitis, focal cerebral arteriopathy, your viral panels are negative, PCRs are negative, metagenomics is negative. Start thinking that we are probably dealing with a vasculitis, which is a part of systemic vasculitis. And then you start thinking or start screening for systemic vasculitis panel. As you all know, I think the panel of this is pretty different. We don't usually get in all cases. But if you're primarily thinking it is a systemic vasculitis which has caused encephalopathy because of the CNS vasculitis, then you start sending your ANA panel, ANA by immunoblot and immunofluorescence. That is to start with, because SLE can also have primary CNS vasculitis or secondary CNS vasculitis. Followed by that, you have this something called the extended autoimmune panel that includes your C-ANCA, P-ANCA, and a lot of other specific antibodies like anti-Jo, anti-Ro, anti-La. These are specific for specific type of autoimmune disorders. For example, Sjogren's disease will have separate. Sjogren's will have anti, Ro 51. We have juvenile dermatomyositis. Sometimes they can also have CNS involvement. So the extended panel of autoimmune workup needs to be done if you're suspecting systemic vasculitis. So this is a child who has pneumococcal meningitis, who has restricted diffusion. So remember, there are few organisms which can cause CNS infection, but also cause CNS vasculitis. So amongst the bacteria, the major culprits, so the leading bacteria which causes vasculitis is pneumococcus. Okay. Followed by that, vasculitis is also known in mycoplasma. So if you say mycoplasma are atypical, but the typical bacterial infection which causes a pneumococcal. Okay. And followed by that, one important thing is tubercular. So if you see Mycobacterium tuberculosis, pneumococcal infection, and mycoplasma. These are the primarily three bacteria which are neurovasculotrophic. So neurotrophic is basically Epstein-Barr, like the viruses which love to be in the nerve, but these particular viruses are the bacteria which like the vessels of the brain. So they're neurovasculotrophic, that is pneumococcus, mycobacterium, and mycoplasma. So whenever you have vasculitis, a focal sign, infarct, start thinking of these bacteria. And you can empirically, start doxycycline if you're thinking it is mycoplasma as well. So why is it so important? Because when you suspect vasculitis, CNS vasculitis, you need to start steroids early on because that is going to have treatment implications. And maybe you need to consider low molecular heparin as well. So I won't go into the details how Streptococcus pneumonia is going to cause vasculitis. This is about the herpes simplex virus, is the maternal vertical transmission. I won't go into the details again. So these are various manifestations of neonatal herpes infection. So the neonatal herpes virus encephalitis can have a different pattern. This can have extensive involvement rather than just temporal lobe. So do remember, pediatric HSV and adult HSV typically have temporal lobe, but you have neonatal herpes simplex. So always remember, because the neonatal herpes simplex encephalitis is basically coming from hematogenous spread and not from the trigeminal nerve. So it's not just going to go to the temporal lobe, it's going to go have a diffuse involvement. So because now we have extensive involvement, extensive vaccination of PCV, now the incidence of PCV has come down, but still amongst the top bacteria, what we have in India, commonly see is Klebsiella, PCV, that is pneumococcus, and Haemophilus influenza. These are the commonest bacteria we see now and then across the India, be it meningitis or any other bacterial infection, even in pneumonias. So I won't go into the details of this. Okay, this is, yeah. So this is a case with bilateral rhomboencephalitis. So again, brainstem involvement, as we typically discuss, it can be seen in enteroviruses and adenoviruses. So coming to the why is it so important to know the drug resistance pattern of your geographical location? For example, uh, why do we routinely give vancomycin? Because though meningitis has come from community setup, we still give vancomycin. Because the logic behind that is there is emergence of multi-drug resistant bacteria even in the community. So if the child comes to you for the first time from the community without going to any other hospital, but still there's a chance that your the child who has come to you has a multi-drug resistant or at least methicillin resistant strain. So that is the reason. So there is methicillin resistant streptococcus, which is very prevalent on the community acquired setup as well. So that's why vancomycin may be considered early on. So empirically, I think ceftriaxone and vancomycin should be given to any CNS infection, bacterial infection. We've discussed this in the previous section. And regarding the repeat LP, I think we have discussed this prior as well. Routinely, if the child is improving in a setup of bacterial meningitis, repeat LP is not indicated. Both IDSA and AAP, that is Infectious Diseases Society of America and American Academy of Pediatrics, do not recommend doing LP routinely in any child. But if you have a child who is not improving or deteriorating, the child's complications have increased after starting antibiotics, or the child is pretty much the same, not improving, then you may consider repeating the LP. These are that is the main indication. Dexamethasone, there's a role of dexamethasone when the patient comes to for the first time. So when we are giving dexamethasone, so do make sure that you have to give it along with the ceftriaxone. But if this child has received ceftriaxone elsewhere and have come to your hospital third or fourth, there's no role of dexamethasone. The dose of dexamethasone is 0.15 mg per kg per dose 4 times a day. That is 0.6 per day, usually given for 24 to 48 hours with maximum 3 days. So this is basically to decrease the inflammation which is happening in the acute stage, which can decrease the incidence of complications like sensory neural hearing loss specifically. There's no role of glycerol. There are a lot of studies which have done. Even a Cochrane review has clearly said that the osmotic therapy with glycerol is not indicated. So do not use glycerol. One specific note here is basically whenever you have a child with cochlear implants. So whenever you have cochlear implants, they have higher risk of. So cochlear implant is basically a metal or a complex metallic implant which is there. So anything which is implanted can have risk of iatrogenic infection or contamination. So whenever you have a child with cochlear implants, again, vaccination with Streptococcus pneumoniae is extremely important. Even for regular vaccination is very important. We have discussed this. One final thing, when I think we discussed this earlier regarding antibiotics, remember, and the logic is pretty much the same in any other condition, like in the systemic. In the CNS, the antibiotic which you choose must be appropriate for the organism you're suspecting. That is the first thing. The sensitivity pattern should be anticipated. The second thing is basically you need to know the penetration of that particular antibiotic. And the third thing, that if you're giving a monotherapy, you need to know that that particular antibiotic should be bactericidal, not static. So penetration, just remember, piperacillin and tazobactam has very poor penetration. Do not consider that in a CNS infection. And they do claim that an inflamed meninges will have higher penetration, but obviously once the inflammation comes down, the penetration will decrease. So there's no point of giving it. So when you want to step up from ceftriaxone, you do consider meropenem right away in a CNS infection, not pipraz. Apart from that, do not choose monotherapy with linezolid because linezolid is bacteriostatic. So if you're suspecting MRSA, vancomycin is a very ideal drug because vancomycin has good CNS penetration and is bactericidal. Management, we have discussed this. I think we'll end this year. Thank you. ఇవ్వాలి ఎండులో ఏంటి చేయడం వచ్చాం నాకు పిలవండి ఎండ్ మీటింగ్ ఉందా ఇదే కదా అదే